This strap muscle of the neck right here, that is cut, that was cut or transected, no, at its tendinous portion, that's the omohyoid, no? Superior to the tendinous segment, that's the superior belly, and then down here, inferior belly. The muscle is the margin, no, or boundary of our neck triangles. So the other strap muscles that are visible right now, but not yet fully or completely visible, that vertically positioned strap muscle right there is the sternohyoid, because one of its attachment point is down here at the sternum, and it is attached to the hyoid bone up here. Okay, let's go back to the internal jugular vein. As you can see, it also originates near the angle of the mandible, no? And it goes down, no? It goes down towards the sternoclavicular joint. Remember earlier I was pointing out to you the sternal and the clavicular heads of the sternocleidomastoid muscle, no? So in between, no, the sternal and clavicular head, no, when you turn the head going or facing the opposite side, when with this muscle contracted, a triangular space, no, will stand out in between the two heads, no? That is where the internal jugular vein is accessible, no, for intravenous cannulation or for intravenous catheter insertion. So let's switch to the other side, no, and let us see once again where that triangular depression is found. So the internal jugular vein, no, is accessible from there, no? Another area where internal jugular vein is accessible is here, no, at the posterior margin of the sternocleidomastoid muscle, no? But it is more directly accessible in this area. So unlike the external jugular vein, no, which will cross the sternocleidomastoid at perpendicular position, the internal jugular that lies deep to the muscle, no, it is positioned, no, parallel to the muscle, or it follows the same orientation or position of the muscle. So let's go back to the midline of the neck. This one right here is the laryngeal prominence, not readily or clearly visible but already palpable. We have the cricoid cartilage of the larynx here. So thyroid cartilage here, cricoid cartilage here. So there is a thin membrane connecting the thyroid cartilage to the cricoid cartilage of the larynx. That is the cricothyroid membrane. This is an important spot because we can perform, no, cricothyroidotomy, no, at this area, no? What is cricothyroidotomy? It is a procedure, no, invasive procedure we do during emergency, no? We can create artificial airway for our patient, no, by doing punching a hole, no, in this area, punching a hole through the cricothyroid membrane. Then we can insert, no, our breathing tube, no, or any available small cylindrical tube, no, to provide airway for our patient, no, with obstruction of the airways at the higher level, no? Sometimes if our patients have severe maxillofacial injury, no, so the upper, no, the more superior airway structures are damaged, and they may be obstructed. For patients with severe allergic reaction, the mucosal swelling in the upper air passages might be the cause of obstruction, or in burn victims with severe edema in the facial and throat area. The edema might present the obstruction in the higher or upper airways. So we can provide airway access to our patient by cricothyroidotomy. Below the cricoid cartilage is already the trachea, but in this case we cannot directly see the trachea, but that dark grayish colored tissue right there, it covers the trachea. That is already the isthmus of the thyroid gland. The isthmus is like a piece of thyroid tissue which will connect the right and the left lobes of the thyroid gland. It contains active thyroid tissue, active thyroid follicles that are also found in the main right and left lobes of the gland.